Turn this off. Sorry. Discuss work-related emotions impact while fostering a culture of compassion. Each session begins with panelists sharing their own personal experiences on a common theme, followed by an open conversation, really designed for the staff to share their experiences and how they feel as they work in Laguna Honda to support them emotionally and psychologically. First session was, as I said, was held on November 5th, and one of the many. Just wanted to highlight that as our care experience team is really working, making sure that we have these things that we had in place prior, or we are bringing some of these back based on the feedback we have received. Also, our Laguna Honda care experience team had hosted several staff events to prompt staff wellness as well, from yoga to Zumba. We also celebrated in the month of October and November. We celebrated Dia de los Muertos. It's a cherished tradition across Latin America, honoring loved ones who have passed away. Also, Latinx Heritage Month in October, and then also Filipino American History Month was celebrated recently. This is really sharing all the wonderful culture that we have at Laguna Honda among staff and residents. So just wanted to highlight all of that. I think it's really sweet to celebrate the different cultures in Laguna Honda. Also, I wanted to thank you, our activities departments. They hosted several resident-centered events as well throughout the month of October and through the month of October, which included our Fall Fest, Pumpkin Patch and the Therapeutic Farm, and also our annual Laguna Honda Halloween party. The pictures are in the slides, as you can see, a lot of residents who enjoy these events. Also, As you know, we are a member of California Association of Long-Term Care, and I wanted to recognize Albert, who was awarded a 2025 recipient of the California Association of Long-Term Care Medicine Leadership Award. And this award recognizes individuals who demonstrate exceptional leadership and making an outstanding contribution in education, practice, administration, and policy in long-term care. CalTCM highlighted Dr. Lamb's role during the pandemic and his work as a leader in education in California and beyond, and his positive influence on long-term care medicine. We're honored to have Dr. Lamb as part of our exec team. So really wanted to congratulate him on his award. Also wanted to highlight we had a team of 7 who attended CalTCM as well, their annual meeting, and we presented 6 posters. So our medical staff, pharmacy, nursing, IPC, and KPO, and one of those poster was selected as, was awarded first place. And this was around, the project was around med simplification that was presented and received the award. So just wanted to recognize all these teams and their work that's happening in Laguna Honda and being shared across California and the nation, all the wonderful work that's happening. So just LHH wanted to congratulate these teams.
Mr. Mitchell, please mute yourself.
I'm sorry.
Please continue.
Last, I also wanted to share, as I mentioned in the last JCC, that we, by next JCC, our South 5 will be open, and just wanted to share that South 5 has officially reopened as of October 6th. We are forever grateful to South 5 team in the critical role they played during the COVID-19 pandemic and caring for a lot of patients with COVID. It's been more than 5 years, so I just want to congratulate the staff for all the work they did in caring for our elderly residents during this pandemic, and really appreciate all their heroic undertaking and their work. So the reopening of South 5 has allowed us more space to be able to serve the residents of City and County of San Francisco. Initially, with the negotiations with the union, we were able to open 1 household with up to 15 beds. And then at the end of the month, we will be able to open up additional beds as we continue to grow our census. And with that, I'll pass it on to Albert to share more updates on admissions. Thank you.
Thank you, Diltar. Good afternoon, commissioners. Just want to continue our executive report with a report out on our census and our admissions. This will not be going slide by slide, but it'll be more of a broader statement about how we're doing. But feel free to ask any questions that you might have about the specifics. So we're continuing to grow our census and support the residents in the city of San Francisco who need SNF services. We are currently at 92% of our monthly goal. And this was primarily related to beds being tied up in South 5, which were previously closed. And as Diltar just mentioned, we've done a lot of work opening that up. And our team, our whole team, our nurses, our physicians, and everybody involved has worked very hard to make that successful. So currently, where we are with South 5 is that we cannot expand, unfortunately, beyond 1 household. There are 4 households per unit. We can't expand beyond 1 household of 15 beds until the end of this month due to the negotiations with our union partners. We are focusing on North Mezzanine, which is our dementia unit, to continue to grow census while we wait to open up more beds on South 5. And that's in partnership with our area nursing facilities and our area primary care teams who are helping to identify appropriate people for the secure dementia unit. We also see a slight decline in admissions in September, so I want to acknowledge that compared to the other months. This is not unexpected, and it's due to a few key reasons, and we are still very close to the target, and we have the ability to ramp up to be able to reach close to our full census by the end of the year. With that, I want to just open up for questions.
Thank you both. Let's wait for some public comment.
Yes. Is there public comment in the room?
Hi, I've written in and I'd appreciate if my letter in toto would go in the minutes. So I wanted to more informally talk to you. We're going into flu season in the winter and the holidays. And this is a time when elderly people especially crash and burn. And you've got medically complex beds opening up. But San Franciscan residents are being transferred out of county. And there is no clear process being used for people with the quote unquote wrong insurance to get into Laguna Honda, but there is a way to do it. And I know that from when I worked at Laguna Honda, and where you can do a one-time contract with an HMO or a PPO, and you can alert the hospital that when the patient is stable for discharge, you can take the patient. There's a way to do this, and we need to get all the stakeholders in one room. I've got a call through to the hospital council. I've got a call through to health service systems, including Supervisor Dorsey, who's on both. And I mean, he's on HSS and the Board of Supervisors. And we've got to take care of San Franciscans at Laguna Honda that need medically complex care. There's not enough nursing homes that can do that in the city. And many of them don't have beds available the way Laguna Honda does now. And for the upcoming winter, there's really no time to be wasted. This will save lives. Sending frail elderly people who don't know their rights and can't advocate for themselves, who have elderly family members who can't drive all the way to East Oakland to see them, is condemning them to death, really. And we need to keep San Franciscans in San Francisco, and Laguna Honda has the medically complex beds open. I ask you to get this on the next LHH JCC agenda, and let's work on this together. Thank you.
Thank you. Is there anyone else? Oh, okay.
Hello, my name is Fred Sanchez. I'm the president of Protect Our Benefits, also a member of CARA, member of San Francisco Retired City and County Employees. And CARA, we pretty much represent every senior group in San Francisco. What I'm here today to talk about is a tragedy that no San Franciscan should ever be transferred out of San Francisco for their care. These people are in their 70s and 80s, you know, they've worked here. And when that happens, depression at this level, when people are at skilled nursing facilities, when they can't see their loved ones, it is just, you watch them decline daily. I mean, it's that rapid when this happens. So all the stakeholders, you talk about union negotiations, all the people that are involved somehow through the Board of Supervisors, because they understand, they have constituents. Hey, let's set up a meeting as soon as possible to see if something can be worked out, because it's not working the way it is today. Thank you.
Thank you. Is there anyone else in the room to provide public comment? And again, this is on the executive team report.
I'm John Jimenez. I'm a long-term volunteer at Laguna Honda, almost 40 years, just to support my two predecessors, what they're saying, my own observation of many people I've known over the years. What can we do to increase the number of beds for people that need long-term care? They don't have to be sent out far away. Thank you for your efforts.
Thank you. Anyone else? All right, there is one remote public comment. Give me a second to reset. Okay, Mr. Manette Shaw, you're already muted. Please begin when you are ready.
I'm ready. Thank you, Mr. Morwitz. Here I go.
As I previously testified, LHH was not going to return to having a full census by the end of December 2025. The state of the hospital report again doesn't make sense. During August, September, and October, LHH admitted a total of 60 patients, but lost 47 patients through planned discharges, AWOL/unplanned discharges, and patient deaths. That yields a net increase to just 13 patients during the past 3 months, and you still have a large number of empty skilled nursing beds. Why are patient admissions taking so long? San Franciscans who want to stay in the city for any nursing home care, whether temporary or permanent, want to gain admission to Laguna Honda. People who are retired from the city and county of San Francisco and still live in San Francisco, like me, want the Health Commission to work closely with the city's Health Services Board to find a way to get LHH's admitting department to help permit waivers to accept city retirees, like me, who have Medicare Advantage insurance gain admission to LHH. I fully support Dr. Teresa Palmer's advocacy in this regard. When I get really old, which may not be long from now, I'd rather be admitted to LHH than be dumped into a substandard care skilled nursing facility out of county.
This
All right.
really needs to be a high priority for this health commission. Thank you.
All right, that ends public comment on this item.
Okay, thank you. Are there any questions or comments from members of the committee on the report? Okay. Oh, yes, Dr. Green.
Yeah, well, thank you for the report. I just had one question. Have you identified which facilities, especially because as I look at the priority 5 group, 35% of the total were denied, and it's 31% of the receiving SNF rehabilitation group. Do you have a goal for what you'd like to see the percentage of appropriate referrals? And also, have you identified certain institutions or referring physicians or organizations that in fact continue to refer individuals that might not appropriately be admitted to Laguna? In other words, it's a lot of work on both sides for both the referring entity as well as for Laguna to go through these. And it would be helpful if you saw certain trends or certain institutions that you'd like to explain what you're doing or explain the parameters more clearly.
Yeah, thank you for the question, Commissioner. And I believe the question was about the percentage of referrals that were accepted and what we've been doing what we would like to see in terms of that percentage and what we're doing on that. Is that right?
Well, it's more the people you're denying and whether they're, when some are closed or withdrawn, but of the total that are referred, like priority group 5, more than 1 out of 3 end up being denied. So what are you doing to identify, any trends or obvious entities that are referring inappropriately? Again, it's a time, the poor individual is, stuck in limbo, and it's time consuming for both you as well as the referred.
Yeah, so thank you for the question. So we have been doing outreach. We recognize that in order to have a healthy Laguna Honda, we want to, as you said, not waste people's time, make sure that we match our resources with the need of the community. And so earlier this year through the summer, we actually conducted extensive outreach, which is what we referred to as our roadshow in previous discussions, to make sure that we outreach to community organizations, hospitals, nursing facilities, referring organizations, primary care clinics that are part of SFHN and other organizations such as the Gray Panthers, to really get the word out there about our admissions criteria, who we're looking for, those people who we really are capable and do a great job caring for, and those people who historically we have had some challenges and historically also got us into regulatory trouble. So those are areas that we are having more scrutiny now on those areas. So we completed that outreach, but we also recognize that outreach is continuing. So the first round of it is completed, and we continue to do education at multiple locations as needed. we have seen over the past year that the percentage of, you were asking about the denial rate, and what we're tracking is actually the number that we actually, the percentage that we actually accept. And we've seen that acceptance rate it's gone up both for ZSFG referrals, so in network, as well as community referrals. So what we're seeing is that in general, that when people are referring patients, residents, San Franciscans to us, that they're doing a better job, and we're doing a better job of making sure that by the time they get to the referral stage, that they are appropriate for our setting. Yeah.
And then if you do deny admission, do you give the individuals and the referrers any sense of where a better placement might be? Because you do know probably who the other institutions are and what, I mean, you've analyzed the case, obviously. Is that part of your protocol?
It is, and that's actually a very important part of what we want to do as a public health institution, is to be able to not just care for those people who we can care for well, but to guide those others who we cannot accept for whatever reason to what we think is the safest and best setting for those individuals. So yes, we've integrated that.
And then the last thing is, I think we have heard loud and clear from the public about San Francisco employees that are retired or in the city, and because they're on MA can't get referred to Laguna. Do you know what steps are really required? Because my understanding is that it's really that the city negotiates with health plans to be the MA provider, and it has changed periodically. And I mean, even the Board of Supervisors and everyone else is in favor. Obviously, it has to be part of this MA contract. So do you know what steps are involved? I assume MA is locked for 2026. Who's really working through those issues, and how can we learn more?
I used to post during this meeting.
I'm going to hand it to my colleague. Okay.
We actually continue to look at all our referral sources to really understand where we are seeing what type of health plans are sending us most of the referrals. And we are engaging with our health network leadership, really see if there are opportunities where we may need to contract with other health plans or Medicare Advantage plans that may be referring a lot of folks to us. But in the meanwhile, we are, as we have shared before, case by case, we do a letter of agreements and do accept these patients when there is a need for them to be admitted to a skilled nursing facility.
Oh, no, sorry.
Thank you.
Yes, Dr. Chow.
Thank you. I had two questions arising from this. One is really on the admissions update, in which you were showing the people, this is on page 11 of your slides, that were being admitted as a percent goal. You have a weekly goal of then a census of 600, and you're at 557. But if we follow this line that you're supposed to be following, we continue to actually be rather flat. So while we're admitting and there are people who are passing away or being discharged, I'm not sure, are you talking about, well, I'm going to be able to admit 636, but that may not be our census, and that our census might stay at 500 something? Or are we talking about that at the end of the year, we're going to have 636 residents? So what's the goal here?
Our goal is to do our best to be able to reach the full census. And as I shared, some of the challenges we have had was really negotiating South 5 opening, which took longer than expected. And we were able to open only one household up to 15 beds and not admit any more residents to South 5 for 2 months, which will be till the end of November. So we are shifting our focus, as Albert shared, really because a lot of our beds currently outside of South 5 are in our secure dementia units. We have about 16, 17 beds there. And then also PMS, which is our short stay rehab unit. We have about 16 beds there. So we're really focusing on our dementia unit because that's specialized beds, engaging with other hospitals. other skilled nursing facilities within San Francisco and our primary care as well to see if there are referrals that we can start admitting to North Med so we can utilize those beds while we wait for opening of more beds in South 5 and then focus on filling the beds on South 5 once we open those towards the end of this month. Remember when we had negotiations, the shift bed last year, there was no staff bidded to South 5 because South 5 was closed. So right now, when we open South 5, the staff is actually being floated to South 5 because we don't have permanent assigned staff. So when we open South 5, we wanted to make sure, one, we could do it safely, that we can staff with the floating staff. And then also, as we are moving residents, there's no negative outcome to the residents. For example, we were looking at making sure that we don't increase the number of falls with this shift when you're moving the residents or not developing any new pressure injuries. So we were monitoring that so we could do it safely and also making sure that we can staff appropriately. So now, towards the end of the month, we will be able to open up additional beds. So we do have plans in place to ensure that we can staff and continue to grow our census. So then we'll really focus on utilizing those 35, 40 beds on South 5 that would open up by the end of this month.
So if I understand, you're still saying that the goal is a census of 636 that you're going to be trying to achieve.
That's what we're aiming for. Would we reach 636? It's hard to say, but we should definitely be able to get close to it.
Right.
For sure.
And part of that is because you currently don't have that capacity of staffed beds, and therefore, on your denial rates, you're not showing us that we don't have an issue of capacity. It would seem to be more an issue of relevance to the work that Laguna does. So where do we get the people to really sort of be admitted beyond? So there's a problem that I'm seeing. There's a group of people applying and we're denying a number of people. Presumably they're being denied for valid reasons, not because we don't have enough space. But if it's because we also don't have enough space, then what is that percent? Because I can't see, following this trend, that we're going to reach the 636. I'm not saying you won't, and you've given us reasons to say you're opening up these different wards, but we don't have the same population applying. I mean, the numbers, then, there is nobody there to fill the beds. And I think, secondly, you might also explain if we are adequately staffed at this time for a larger hospital by the number of beds, why we would now be looking for new staff in order to fill these spaces.
So I believe you have, thank you for your question, Commissioner.
Yeah,
Couple
there's two
different parts to the
questions.
question. One was about staffing.
Correct.
And one is about whether we have the referrals for these beds. We absolutely have the referrals. We actually have several residents in the city that's actually waiting for a bed because we don't have an appropriate bed available yet outside of North Mez. So especially most of our units are around 47, 48. We can get up to 49 on each outside of South 5. So our long-term care beds, there's very limited number of beds that we have vacant. So as soon as we can get capacity on South 5, which, like I said, since South 5 was not open for almost 2 months, that slowed our ability to be able to continue admit at the same rate where we were admitting almost 35 or 40 patients a month. It really, you saw a slowdown. That was really because we didn't have enough vacant beds to be filled. So that's where the slowdown was. So now as we can open South 5, we will be able to increase the admission rate, which as we did in the past. But North Mez, for example, 16 beds, right? It really is hinged upon us being able to identify patients who really belong in those beds, right? So we are making efforts to reach out to other facilities so we can continue to identify patients who match that type of bed. Even if we fill South 5, for us to reach capacity, those beds will have to be filled as well.
So are we keeping a waiting list?
So we have several residents who are waiting currently for the bed. So as soon as we can open South 5, we are able to bring these residents in, absolutely.
And then could you explain the staffing question?
Yes. So initially when the bid happened, there was no staff that was bidded to South 5. They were only bidded to rest of the units. So now when we are staffing South 5, we have to float staff from other units to South 5 because there's no permanent bidded staff to South 5. We are currently working in negotiations with the union for another shift bid, a staffing bid that would take place probably in the next month or two for us to be able to bid staff housewide to all the units. So that should also help. But currently we are having to float staff on a daily basis to staff South 5.
But if our overall staffing in terms of numbers of employees we have, we're really set for the 700 goal. I'm still a little confused as to why we don't have enough people to open these wards sooner.
So
I mean,
yes,
we're not talking about hiring more
yes,
people, are we?
absolutely. I know exactly what you're referring to. On a paper, we actually have enough staff for about 700 plus residents, and that's what you're referring to, and that's absolutely correct. But when we're looking at the actual availability of the staff, we have a large number of staff that's out either on different types of leave, workers' comp, FMLA, or daily sick calls, that when we look at the available number of staff, that's where we see that we do not, we run into challenges. That's where you see that we have overtime, or whether we use registry sometimes when we have to staff, because there is a large number of staff that is unavailable. And we are actually, that's part of the A3 that I shared with you in the past, is where we're really looking at staffing to see how we can increase the availability of that staff. For example, when they're on workers' comp leave and somebody's out for 2 years, if that's the dead FTE, that we could actually probably hire somebody temporarily into that role instead of having that FTE that's tied up because somebody's out for 2 years. So we're really looking at how can we take some of these FTEs back and really increase our staffing. Also looking at how do we reduce our sick calls. Part of that is probably staff burnout. Some of it is behavioral that we want to address, make sure that there's some accountability as well. We're really looking at that. We're also looking at hiring. We had a lot of vacancies. We had about 8 or 9 RN vacancies, several LVN vacancies and CNA vacancies. That you'll see that in the vacancy report. And we're really pushing to make sure that we can hire folks into that to really provide the relief to the staff and have staffing to be able to care for the increased census that we will have.
Well, I really appreciate your more extended discussion to our understanding as to the whole issue of staffing. So thank you very much.
Thank you.
Thank you. And I just want to take this opportunity to congratulate Albert, Dr. Lam, for your award. It's, we often ask questions about some of the things that we see that are, problematic at times at Laguna Honda, and we rarely have the opportunity to really sort of acknowledge, the fine work that others external to Laguna Honda are acknowledging. So wanted to sort of, for the record, thank you for your dedication and the leadership that you are exhibiting, such that an award is merited. Thank you very much.
Yeah. Thank you very much. It's an honor, and all leaders have great leaders that work with them, and we have a great leadership team and a great team at Laguna Honda. So it's my privilege. Thank you.
Okay. Thank you. And so just one last piece about the admission. So the other neighborhoods are going to be open after November, so starting December 1st, and we have referrals that are being processed in addition to the waiting list in order to rapidly fill those, again, pending the appropriate staffing, processes that are in place also to make sure everything is sort of balanced out between the staffing and safety and filling the beds.
Yes, thank you for your question. Absolutely. Right now we have 10 patients in South 5. We can go up to 15. So currently what we're doing is looking in-house to see if there's a resident who would like to move or appropriate for South 5. So we can go up to 15, and we can continue to have capacity to continue to admit in the other units. And as soon as I think the date is around November 25th, when we would hit the 2-month period that we had negotiated with the union. And once we hit that date, then we will start working with the staff to open up additional bids. But we want to make sure that we do it safely and continue to staff them as well. But that's when we will be able to bring additional households online so we can start admitting. And as I shared, yes, we do have some patients who are already waiting, and then we'll continue to work to make sure that we can really push the referrals and engage with other area hospitals so we can continue to grow referrals and admit into South 5 and other units.
Okay, thank you. Any other questions? Okay, appreciate that. We can move on.
Thank you.
Thank you.
We can move on to item 5, the hiring and vacancy report. And I believe Ms. Thorson is joining us remotely.
Oh, there we go. There I am. Good afternoon, all. My name is Erica Thorson. I am the Director of Hiring Selection here with the Department of Public Health. Commissioners, thank you for taking the time to hear about our hiring activities. Seems to be a bit of a timing disconnect where Diltar just shared about a number of RN, LVN, other job class vacancies. Well, you'll actually see in the report is that we had, I should say, at the end of October, a 0% vacancy rate. Timing sometimes gives us different information, which is what happened in this instance.
Erica, could you speak up a little
Yes,
bit? The sound in here is not so great. Could you just go up a notch or two? Thank you.
I can do it. I'll use my outside voice. As I was mentioning, is that our vacancy rate was showing at a 0% with the attrition savings baked in. So the numbers differ a little bit from what Diltar had mentioned, simply because of a timing issue is what I would believe it to be. In October, we did process a total of 29 appointments. It included 3 new hires, 25 internal transfers, and 1 rehire. I'd like to highlight that 25 of those transferred were home health aides transferred into CNAs, certified nursing assistant roles. This transition was part of the planned phase out of the HHA job classification at Laguna, and we're proud to have supported these employees in continuing their careers with the Department of Public Health in this new capacity. During the same time period, we had 2 non-retirement resignations as well. From the hiring and selection standpoint is that, excuse me, as we approach the end of the calendar year, our hiring and selection teams focused on strengthening our internal capacity, improving our processes, ensuring a smooth hiring practice for our hiring managers, our candidates, as well as our employees. We've launched a series of peer-to-peer training sessions that are designed to reinforce our best practices, share new tools and tricks and systems that will help make everybody's job easier from the hiring perspective, and ensure a consistent, high quality, best in class experience for all of our constituents, whether they be our hiring managers, our candidates, or our employees alike. And one, I will give you all a little preview to this, is that it hasn't been well communicated out yet, but we are launching a new reassignment process for our registered nurses. It is coming in the form of a new form, a Google, so much more automated than it was before. It was manually done in the past. We're looking at launching that in the coming weeks. So really to streamline the practice, make it easier for RNs to raise their hand to reassign into other roles within the Department of Public Health. We're really excited about that in partnership with SEIU to make that come to fruition. And on that, I will pause and take any questions you may have.
Thank you. Is there any public comment?
Is there public comment in the room on this item or on the HR report? I don't see any hands. And let me see if there's anything remotely. I do not see any hands.
Okay, Erica, I just had one question. How are we doing on the hiring of the DONs?
We are in the interview stage. Diltar, I see Diltar standing up. He'll probably be able to give you much clearer direction than I.
Yes. Thank you, Commissioner, for that question. So we do have a good group of candidates that we have actually gone through a screening criteria and identified. There's 13 candidates that'll be moving to a first round of interviews, which we are scheduling starting this week and next week. And then once we identify candidates from there, we will have a second round of interview to identify 2 DON candidates. So that's actually moving forward.
When do you expect to have sort of a final list of candidates ready to ready to go, or the final 2 or 3?
So it looks like probably beginning of December, we should be able to identify a candidate. Given the last week of November will be a Thanksgiving week, so we may not have interviews in that week. You know, a lot of people are out on vacations and with families. And given that, and then process of making sure that people can go through their physicals and all the hiring paperwork that needs to happen, looks like probably in January, we should be able to have them in place.
Okay, great. Any question? Oh, okay, President Green.
This may be secret information, but do you know what percentage are actually internal candidates? And also, what are the skills that the top 2 or 3 skills you're going to prioritize for people to fill these positions?
So we do have internal and external candidates. I'm not sure if I can disclose how many, but there are both. And we do look at a selection criteria based on their minimum qualification as well, and looking at making sure that, you know, their education level, their SNF level of experience, their overall experience as in the management role. So all of those things are looked at when we're selecting the candidates, but it's basically the criteria is fair across all of the candidates. Right, so.
And who's on the selection committee?
So as far as the interview panelists, we wanted to make sure that we have a wide range of folks, and the decision is made by a good group of people. We have folks from our exec team, folks from frontline nursing staff, managers, nurse directors, also our health network partners as well, because we understand these are very high level positions, and we want to make sure we bring in the right candidates. So we really have a wide range of panelists on the interview panel.
Great, thank you.
Thank you.
Dr. Chow?
Yes. I'm just wondering, trying to understand, because we've had different structures, that this director of nurses that you're looking for, what role will that director of nurses have, since you've got, what, 2 different towers and all, and there was in their recommendations to perhaps do a restructuring, or is this a advisory role, or what does the director of nurses do?
So the director of nurses, this was in line with the recommendations from HSAG, where instead of a CNO, that we had 2 directors of nursing role created, where one director of nursing was overseeing 1 tower, partnering with ANHA, and then the second director of nursing was in charge of the second tower, a partnership with and the second ANHA. So that's the structure that was actually recommended through HSAG, and that's what we have followed. I think you may be also referring to the additional recommendations having 2 ADONs in addition to the DONs, perhaps, and that's something that we have not implemented yet. But the 2 DONs will be, the structure would be very similar to what we had when we had our previous DONs, and they will also be overseeing clinics and our acute care as well as part of their duties.
So there still will be a director of nurses for each of the towers?
Yes, that's correct.
This director of nurses has what role within those towers? I mean, I understand about the acute unit and so forth, but
I mean, as a DON, they'll directly report to me. This is instead of 1 CNO role, we have 2 director of nursing roles. They will be overseeing all aspects of care within the hospital, but they may have some additional departments that would be assigned to them. Like 1 director of nursing may also, in addition to their role as overseeing 1 tower, they may have nursing ops as part of their responsibility. And then the other DON may have PMA as part of their responsibility, but they're in charge of the overall care of the residents in the facility.
So the person we're trying to hire, or are we trying to hire 2 people?
We're trying to hire 2 people, which previously, if you remember, Tracy Brown and Terry Grados were our 2 directors of nursing, and those are the 2 roles we're trying to fill with their departure.
2 directors of nursing.
Yes,
that were
that's correct.
Okay. I wasn't clear about that because all these titles are confusing me. Okay.
Yes.
Thank you for the clarification.
Thank you.
Okay. All right. I guess no other questions. We can.
Thank you. Is it possible to send the Don job announcement to me to forward to the commissioner so they can see the job, the education and qualifications and all the stuff that you're talking about? Is it posted somewhere, right?
I can
Okay.
get it for you, Mark.
Okay, thank you. Yeah, just because I think it sounds like they're interested in seeing the details.
Great, appreciate that.
All right, thank you.
Absolutely. Thank you.
Have a good one. Item 6 is a regulatory affairs report.
Good afternoon, Commissioners. Nazanin Zahir, presenting for Geraldine Mariano. I'm going to share with you the Regulatory Affairs Report. It will cover both the months of September and October. For the 2 months, Laguna Honda submitted a total of 34 facility-reported incidences to CDPH, and 11 anonymous complaints were shared with the facility by CDPH. CDPH has not started their investigation for 15 facility-reported incidences in September and 17 reported in October. We did have a total of 5 site visits between September and October. CDPH investigated 47 facility-reported incidences and 11 anonymous complaints. For the FRIs, 6 were from May, 11 were from June, 15 from July, 13 from August, and 2 from September. 1 out of the 47 facility-reported incidences did have an exit of potential deficiency, but we're still waiting for that statement of deficiencies. And I understand CDPH is actually still discussing that verbal outcome to see if that will come to fruition. And the facility, in addition, while 46 facility-reported incidences did have 0 noted deficiencies, which is excellent. Out of the anonymous complaints, we do, at the time of this report, we had an outcome pending, but I'm happy to say that all the anonymous complaints have 0 deficiencies. That was determined just on Friday. At the time this report was developed for you all, we have 58 cases still remaining to be investigated by CDPH. Happy to take any questions.
Thank you, Naz. Public comment?
Is there public comment in the room on this item? Regulatory affairs report. Okay. Don't see any in the room. We don't see any in the room. And let me just see if there's any hands up. No hands up for this item remotely.
Okay. Any comments or questions from members of the committee? Okay. It doesn't look like there are any. Thank you, Naz.
You're welcome.
Thank you.
And the next one.
Okay, we can move on to the hospital policies.
Wonderful. Presenting on behalf of Carmen Trin for this month. Also, thank you for reviewing policies in October at Health Commission. Very much appreciate it. So the policies being presented to you now are just for the prior month. For your review and approval, the facility is presenting 15 policies for consideration. 3 facility policies are being recommended for revision, 8 departmental policies are being recommended for revision, and 4 departmental policies are being recommended for deletion.
Okay, is there any public comment?
Any public comment in the room on policies? There's no remote public comment on this item.
Okay, and thank you for the swift response to the questions that were already posted. If there are any additional ones. Yes, Commissioner Chow.
Yes, yes. And I would like to echo thank you for the ability to even answer these questions in this depth.
And please speak closer.
So I guess my concern is actually still with the G2, and I'm not saying that it is incorrect, but to remove the Glasgow criteria as even perhaps a guide for people to evaluate sort of bothers me a little because it then seems to open up that the evaluation of a neurological deficiency is sort of left very subjectively at the hands of the physician. And the answer you provided to me was that, well, the physician can always send the patient out to receive the Glasgow scale. And while I'm not necessarily saying that you should mandate the use of the Glasgow scale, I'm just wondering if it could be available as a resource within this, because the resident physician, that is the physician in residence at that point, who may not even know the patient, may use something more objectively. So that's in your G2 0 so by removing a objective scale, it sort of really leaves it very subjectively for such an important issue as the head trauma. So
Maria Antoc
I'd just
is
like
gonna
to
recognize.
get some rationale and why we're removing a potential tool. I mean, if we could write it in as a tool, as a appendix or something, that would at least give an opportunity for the resident to use something that is really proven and not wait until we go to an acute care hospital.
Hello, Commissioner. My name is Maria Antoc. I'm the interim DON for Laguna Honda. So we had several discussion about Glasgow Coma scale, and this assessment is commonly used in acute and not in a SNF setting. We have other ways of assessing a resident without including Glasgow Coma, but this is something that we could maybe discuss again. We did, like after we review, determine that, at least for SNF, that we will not be moving forward with, checking residents for this type of assessment.
Oh, well, maybe Dr. Lamb could answer better in terms of, I'm just looking at the poor, say, the night physician who doesn't really know the patient and is looking for a way of trying to understand if a patient is going to slip into, a coma or something.
Thank you, Commissioner, for your question. I was part of some of the discussions around this, so I'll just share a little bit about what the discussion was. There are elements of the Glasgow Coma scale that are still part of the nursing assessment. I think that what removing it from the policy does is gives the team flexibility to choose which of these standardized scales that they would want to use and adapt it. The GCS is something that's used in EDs. It's used in the field for EMS. It isn't used as often in nursing facility care, but the general assessment that you'll see, the level of consciousness, the vital signs, pupillary changes, headache, vomiting, and changes in sensation or ability to move, are shared assessments with the Glasgow Coma scale. That is, I believe, what I recall the reasoning for removing it from the policy, but it doesn't necessarily mean that we would not use it in the future or even in practice. That would be informed by our clinical nurse specialists. Yeah.
Right. I only suggest, I mean, this looks like a minimum, which is appropriate in terms of timing of vital signs and so forth. And I'm just concerned that we also be able to provide tools to a physician to be even more objective. There are, I mean, it goes back to almost, I recall from medical school, we could really document very well that a patient is going into coma, and we don't really know at the time we should be doing something about it. So, so I'm very sensitive to a need to try to be as clear as possible, especially in a potentially curable case.
Yeah, we appreciate that, and we will take that into consideration.
Sure. Thank you very much.
Any others? Okay, then we should have a motion to recommend approval of the policies and procedures to the full commission.
So recommended.
I will second that.
All those in
Okay,
favor?
all those in favor?
Aye.
Thank you very much. Commissioners, you're now in consideration for closed session. Is there any public comment on the closed session? Let me check remotely. I see no public comment in the room. I see no public. I see no hand for public comment that way. So please
Okay,
move
is there a
forward with the
motion for a closed session?
So moved.
Second?
Okay, all those in favor?
Aye.
Wonderful. Okay, so all those not attending closed session, would you please leave us and have a lovely day? Thanks for attending. And those who are participating remotely or watching remotely, you will not see or hear the room while we were in closed session. Give me a minute to get this done.
312.
Let's consider a motion. Well, you, in closed session, you approved the credentials report and the PIPS minutes report. Please consider a motion whether to disclose or not disclose discussions held in closed session.
Move not to disclose.
Second.
All those in favor?
Aye.
Right. And now please consider a motion to adjourn.
Move to adjourn.
Second.
All those in favor?
Aye.
All right. Please give me 30 seconds to take us down. Thank you all who are watching and
that's
for
what I was
those who
wondering.
presented.